So let's start with the ENT part 1. We will cover half of this topic in this part. Okay. So first we will start with the first topic, that is subglottic stenosis. The image of the drug given below, since it is showing mitomycin C, it is used in the subglottic stenosis. Okay, which all question can come regarding this. Mitomycin can be used in subglottic. It acts by how it acts. It inhibits the fibroblast proliferation and thus inhibit the stenosis. Okay. Mitomycin C belongs to which class of the drugs? So we have read in pharma that it is an anti-tumor antibiotic drug and it is an alkylating agent. Okay. Next, topical mitomycin C in ENT is commonly used to prevent subglottic stenosis. It can be post-surgical or it can also be caused due to other reasons like intubation, etc. Intubation complication. Another ophthalmic use of mitomycin C. The ophthalmic use of mitomycin C is used in trabeculectomy for the glaucoma. In trabeculectomy, we cut the trabeculectomy. We make the opening. It is used when there is hazy cornea. Whenever there is clear cornea, we do a procedure called a goniotomy. Is done. Systemic adverse effect classically associated with mitomycin C. Since mitomycin C is an anti-cancer drug, alkylating agent, and it can lead to the myelosuppression. It can lead to the myelosuppression. Next topic in the recurrent laryngeal nerve. We all know the recurrent laryngeal nerve is a branch of the vagus nerve. Following total thyroidectomy, a patient started to have difficulty in breathing, dyspnea, and repeated attempts to extubate were unsuccessful. This means that there is adduction. So most commonly is a bilateral recurrent laryngeal nerve palsy. Superior laryngeal nerve palsy comes with the different features, like it is mainly by the cricothyroid muscle, which is the main tensor. In unilateral there will be a compensation. So it cannot be the answer. In hematoma usually do not can present with the following features. But since there is a mentioning of the thyroidectomy, so we can also root out the hematoma. We can read related points like most common nerve injury during thyroidectomy is, since we have read the recurrent laryngeal nerve, bilateral recurrent laryngeal nerve causes the abductor palsy. Since abductor palsy and both will be adducted, so abductor palsy will be there. Abductor palsy, because these are the new fibers and more prone to trauma. In case of unilateral recurrent laryngeal palsy, so the position will be one in the median and one will be the paramedian, and hoarseness of the voice cannot be able to communicate, and hoarseness of voice will be there. Nerve supplying cricothyroid, we have mentioned only the cricothyroid is measured by the external laryngeal nerve, superior external branch. Internal branch supply the sensations. So it can lead to aspiration. If internal laryngeal nerve and internal branch is damaged. Most important anatomical relation of the recurrent laryngeal nerve during the thyroid surgery is, it's a very important question, like inferior thyroid artery. How we can suspect like this is the artery, inferior thyroid artery, and it is close relation with the recurrent laryngeal nerve. It can be a potential question. Okay. Next, let's discuss the question. A female patient presents with a nasal obstruction and nasal discharge and loss of smell. On examination, foul smelling discharge and yellowish green crust were present. Since crusting is present, she is found to have merciful anosmia. Merciful anosmia, that is anosmia is there, but she is unaware. So it mainly lies due to atrophic rhinitis, and in atrophic rhinitis there is a paradoxical thing that there is a roomy air cavity, but despite roomy air cavity, nasal obstruction is present. Due to the crust formation. Nasal polyps are in allergic rhinitis, inferior turbinate hypertrophy, and foreign body. These are can be ruled out easily. Most let's study other points related to this. Most characteristic clinical feature of the primary atrophic rhinitis is, so primary atrophic rhinitis, foul smelling. Since primary atrophic, it can be due to the estrogen deficiency, it can be due to vitamin D deficiency, it can be due to infection like Klebsiella infection can also be there. Most commonly associated Klebsiella ozonum. Characteristic finding on nasal examination in atrophic rhinitis is roomy air cavity, but obstruction is there due to the crust. Type of anosmia seen in mercial anosmia. Surgical procedure we can do junks या modified junks. Important है, in junks nostrils are closed, but in modified junks nostrils both are not closed, it can be the important question. Okay, next let's move to the third with question. A patient present with the emergency epistaxis. There is no relief on pinching or trotters is done, but it's no relief. Nasal packing was done, packing was also done, no relief. What will be next step? Though basically we will like it is sphenopalatine artery. This is a little space. It comes with this sphenopalatine, anterior ethmoidal artery. Posterior ethmoidal artery is not a branch. Superior labial and greater palatine artery. First we will try to ligate sphenopalatine. If this fails, then we will ligate the maxillary. If this also fails, then we will external carotid. If this also fails, then interior ethmoidal artery. Posterior ethmoidal artery never the answer, because it is not a form. It do not form the Kieselbeck's plexus. Okay. So let's with the most common site is Little's area. We have done it. Most common artery responsible for the posterior epistaxis is the sphenopalatine artery, known as artery of epistaxis, sphenopalatine. If epistaxis persists after the interior posterior nasal packing, the endoscopic tespal, the transendoscopic sphenopalatine artery ligation, and is formed by which branches which arteries? Anterior ethmoidal artery, we have mentioned it, sphenopalatine artery, greater palatine, and superior labial artery. Next, now patient present post tonsillectomy in a recovery room starts bleeding from the operative site. Okay, in the operative room, recovery room, it is present in recovery room, not in during operation. Okay, not during operation. Blood clots were present. What we will do? It's a cause of the slippage of ligature due to arterial bleed. So we will immediate shift and religate it. So this can be answer. Shift to auto stop, and when we have shifted, then remove the clots. It cannot be answer. Start anticoagulants and repeat. No. Blood transfer. No. We do not have to wait, because it is an arterial bleed. It can lead to serious complication. Most common complication. The most common complication of tonsillectomy is posterior tonsillectomy hemorrhage. Primary hemorrhage after occur how many hours? Reactionary, primary, and secondary. Primary is within first 24 hours. Secondary is after days due to the infection, and venous involvement is there. Secondary hemorrhage after 5 to 10 days due to the slow separation. Immediate management of active post tonsillectomy bleeding in with clots is, if bleeding is present and clots are present, the shift to OT and religate. Most common cause of the secondary hemorrhage after tonsillectomy is infection of the tonsillar fossa. Secondary hemorrhage is due to the infection. Okay. Next, a patient present with a history of chronic ear infection, present with a fever, headache, and vomiting. Since fever is present, headache is mentioned, his brain CT is shown this way. So, since this is a temporal area. It can be the temporal lobe abscess. Usually cerebellar abscess is not visualized in this city. Subdural abscess will be more toward the subdural space, and meningitis will present within more presentation like knuckle rigidity and etc. Okay, the most common intracranial complication is a complication of COM, which is intracranial. Extracranial most common complication include acute mastocytitis. The most common complication include the brain abscess. Most common site for the brain abscess is temporal lobe. Second most intracranial is the cerebellum. It can be written by the cerebellum. So first is temporal, followed by cerebellum. This is the intracranial complication. Most common organism causing the otogenic brain abscesses. Then otogenic in every answer we have either strepto the staphylo. In case this is streptococcus, and group we can have a miliary group. It is miliary group. Streptococcus miliary group. Characteristic CT finding with ring enhancing lesions. Since it is a ring enhancing lesion, an enhanced ring is present with surrounding edema. Okay. Next we will go with facial nerve. A patient present with the complaints of inability to close the eye. So eye affected, drooling of saliva affected, and deviation of the angle of the mouth. Angle of mouth is deviated. Which of the following nerve? Since all is a presentation of the facial nerve, it's the presence of the facial nerve palsy. Okay. Trigeminal nerve will non-oculomotor will be of eye movements basically, and gossamer will be of tongue and uvula, and basically related to cuff reflex, etc. A patient presents with inability to let's take some other questions. A patient presents with the inability to close the eye, drooping of the angle of mouth, and loss of forehead wrinkling. Since the facial nerve palsy. A patient with Bell's palsy complains of increased sensitivity to sound. Hyperacusis is present. Damage to which of the following is muscle? Stapedius. It can be hyperacusis is also due to stapedius muscle, because facial nerve supplied nerve to stapedius, which help in dampening the loud sound. Dampening of the loud sound. Loss of taste sensation from the interior 2/3 of the tongue. Important है. Interior 2/3, posterior 1/3 uvula. Interior 2/3 is carried by coda tympani. Posterior 1/3 is carried by glossopharyngeal, and left is carried by the vagus due to the injury of the which branch of facial coda tympani nerve. A patient will undergo parotid surgery develops a facial asymmetry and ability to bend the facial nerve. Facial nerve is closely intact with the parotid gland. Because parotid gland, facial nerve run along with it. Superficial to deep structure can be asked in the parotid gland relationship. First is vein, then is nerve, then is the artery, and behind its retromandibular veins are also present. In facial nerve palsy, inability to cause the odor occur due to which of the muscles? Since eyes are supplied by the orbicularis oculi. Orbicularis oculi will be the answer. Adult man in restaurant suddenly begin choking due to the oropharyngeal obstruction. He is conscious. Since he is conscious, if mentioned unconscious, we will initiate CPR. Since it is conscious, then we will do a Helmich maneuver, that is backward thrust we will give. A conscious adult starts choking while eating and unable to speak and cough effectively, but it is a Helmich maneuver which is include abdominal thrust. In an unconscious adult suspected with foreign body obstruction, what is the next step after starting CPR? Essentially, unconscious adult has CPR. We check for the mouth. We will open the mouth and check for any visible obstructions. Okay, and give breath. If not give breath if obstruction not present. In an infant with choking due to the foreign body, which procedure is recommended? Since we cannot give Helmich maneuver since child is small, we will back close and chest thrust. In a pregnant woman or bees with the airway obstruction, which maneuver should be used instead of abdominal thrust? Cannot be done. It can cause to fatal damage. We only give chest thrust. Blind finger sweep in choking is generally avoided because it may cause which of the following complication. A blind finger whenever there is some foreign body. Blind finger can push the bolus more inside, so it can worsen, so it is not recommended. Okay? Not recommended. A patient presented with a firm, tender, slow growing mass below the ear. Since it is below the ear, which would have falling, it is due to basically parotid pathology. We can abscess also, it can be parotid cancer also, like pleomorphic adenoma if given. Then profile will be changed, like the features will also be present. A patient presents with the painful swelling below the ear with a fever and pulse and discharge Stensen's duct. What is the most likely Stensen's duct parotid abscess? A patient swelling in parotid region that increases while chewing the food, which is the most likely condition. So it is a parotitis infection. Which duct drains the parotid gland? The duct where duct is Wharton's Stensen's duct. Stensen's duct drain the parotid gland. Injury to which nerve is a major concern during parotid? We have read it earlier. Facial nerve. Which muscle is pierced by the parotid duct before opening into the oral cavity? Since parotid is present in this nerve, here buccinator is present. Here buccinator is present. Buccinator is pierced. Buccinator pierce. Superficial muscle is buccinator. Buccinator is present. Next we will do with serositis media. Next we will serositis media. In a child, in a 5-year child with a reduced hearing for the past 2 to 3 months, otoscopy findings. Since we are seeing air bubbles, it can be due to the SOM, serositis media. Serositis media. Acute otitis media will present with other features like cartwheel appearance. Okay, laryngeal bladder will viral fever, prodrome will be there. Okay, a child present with hearing, dull ache and retracted tympanic membrane. Most common retraction is type 2 retraction. Type 3 is up to the promontory. Most common cause of serositis media in children is dysfunction of which structure? Eustachian tube. It helps in the barotrauma management, equalizing the pressure, and also help in the drainage of secretion. Which investigation is most useful to diagnose middle ear effusion in serositis media? Tympanometry is done. Tympanometry can yield with result like tympanometry A, B, C. A can be due to the AS will be given atosclerosis. Okay. B is the flat type. C is negative. Flat type is seen in the B is latest serositis media. So if B type tympanogram is visible. A persistent otitis media, AD can also present disruption. D for disruption of ossicle. Otitis media with effusion in children is commonly treated with insertion of which device? Grommet insertion is done. Ventilation tube. In serositis, which type of hearing loss is present? CHL, conductive hearing loss, which is a middle ear pathology. Next we have Samter triad. Samter triad with aspirin sensitivity, bronchiectasis. Okay, Samter triad. And asthma sinusitis. Asthma sinusitis is Samter triad. It may be attributed to Samter. Aspirin is the answer. Aspirin can be the answer. Samter triad consists of the asthma, nasal polyps, and sensitivity with aspirin. Samter triad is also known as Bird syndrome. Aspirin exacerbatory respiratory disease, so it can be ruled out from the option. The pathophysiology of Samter triad involves increased production of which of the inflammatory mediators? So aspirin is a COX inhibitor. So LOX pathway will be upregulated, so leukotrienes will be produced more. Which class of drugs is contraindicated? All the NSAIDs, almost contraindicated, but especially aspirin. Which medication is commonly used to manage leukotriene? Leukotriene inhibitor is montelukast. Interleukin 1 inhibitor is omalizumab. High frequency hearing loss. A 70-year-old patient with decreased hearing of high frequency. First we will learn about the two parts. It's the base, is the apex. Sound waves come from, since the distance is low, this distance is high, so wavelength will be more, frequency will be low, here frequency will be high. This is near the apex, this is near the oval window, and this is near the helicotrema. So now we can easily answer the question. Higher frequency sound mean low wavelength near the oval window. So answer will be the oval window. Okay. High frequency sounds are attracted with the base of the cochlea near the oval window. Low frequency are helicotrema, apex. Which of the cochlear produces endolymph and maintains the endolymph? Stria vascularis produce endolymph. The basal membrane supports which sensory structure responsible for a hearing organ of Coti? Vibrations from the stapes foot plates are transmitted to cochlea through which of the following? Oval window. Because stapes is present like this, oval window, then we have cochlea, oval window, and stapes, foot plate of stapes. This is foot plate of stapes. Okay. Next, nasopharyngeal angiofibroma. A 20-year-old patient presented with an unilateral nasal obstruction, recurrent bleeding, and an endoscopy CECT in with posterior guana on the nasopharynx, but can be nasal angiofibromas. In nasopharyngeal angiofibroma, since is angiofibroma vessel disease, biopsy is contraindicated. Okay. Female teenage present with a recurrent epistaxis urinary nasal obstruction. Vascular mass is in nasopharynx, but in the juvenile nasopharynx, since the teenage juvenile nasoangiofibroma most commonly arises from the sphenopalatine foramen, which is in the posterior lateral wall. which was preferred by before the biopsy. Before biopsy, we have to do CT. Why is biopsy contraindicated? Because risk of severe bleeding can be very without increased vessels are present. What is the definite treatment for juvenile nasopharyngeal aberrama? The juvenile nasopharyngeal aberrama is embolization followed by surgical excision. Okay, for embolization first. Next, a fossa of Rosenmuller. This is a torus tuberous. This is eustachian tube opening, and there is the fossa of Rosenmuller. Identify the structure marked in the image, which do not have marked. The most probably image will be like this. The fossa of Rosenmuller has there. Fossa nasopharyngeal carcinoma is the most common site for the fossa of Rosenmuller if present with unilateral hearing loss in adults. Okay, the fossa of Rosenmuller posterior to which structure it is present before the top torus tuberous. Nasopharyngeal carcinoma is most commonly rises from which site in the fossa of Rosenmuller. The nasopharyngeal opening of the eustachian tube is present in which part? It is present in nasopharynx, not in the oropharynx. It is present upward nasopharynx. Enlargement of which lymphoid tissue in the nasopharynx commonly causes the nasal obstruction in the children. It is adenoid. And elevation of the formed cartilage of the eustachian tube in nasopharynx is called a torus tuberous. We have read it. Okay. Next we will go to frontomucosal. 30-year-old patient with non-axial proptosis. This is sad. Patient gives a history of road traffic accident. CT image is given below. Like most likely CT image will be like here will air be present. Here will be tissue. More tissue will be present. So we can go with the frontal mucosal. The patient presents with a slowly progressive non-axial CT, expansile abdomen and frontal sinus. Here frontal mucosal is most common. Which sinus is most common in mucosal? Frontosinus, which is the most common cause of the paranasal mucosal due to obstruction. Frontal mucosal commonly causes proptosis in which direction? It causes since after present since like this eye frontal sinus are like this. If mucosal will be present, it will push the downward and outward and down and out. Okay, downward and outward displacement. With a treatment of choice, we can give it the FES. We can a functional endoscopic sinus surgery. Okay, next last question. The instrument shown in the image is not used in which of the following? Instrument is not shown, so we cannot do this question. Okay, so I will be uploading next part at night. Today ENT will be completed. Okay, hope you will like, subscribe. All subjects will be covered before 20th. Okay, thank you.